Hello and welcome to my channel. In this lecture we'll be discussing the knee joints, so let's begin. The knee joint is a synovial hinge joint. Actually it's a modified hinge. That's the old classification. Modified because it doesn't only has flexion and extension, it has rotation of the femur on tibia or tibia on femur in locking and unlocking of the knee. So that's why it's not only classified only as hinge, as modified hinge, but the new classification is a condyloid joint between the condyles of the femur and the condyles of the tibia. The articular surfaces are with least contact in flexion, as you can see here, and maximum contact between the femur and the tibia in extension. While there's another bone that you shouldn't forget about in this location, it's the patella. It forms another joint with the femur. It's called the patellofemoral joint. It's a plain synovial joint, and it takes much of the lateral condyle of femur and little of the medial condyle of femur. So it's this triangular area that will articulate with the patella. As you can see, the maximum surface with the patella is during flexion, while the least is during extension because the patella is pulled up. Now the medial condyle of the femur, the articular surface is ovoid and larger than the lateral condyle, which is rather rounded. Only part of the lateral condyle that shares into the knee joint. Okay, so these are the articular surfaces. Don't forget the femoropatellar joint. The capsule articulates around the articular margins, of course, and it's thicker posteriorly than anterior, and because it's enforced in with ligaments at the posterior aspect. Anterior superiorly, it's deficient behind the quadriceps tendon to give the to form the suprapatellar bursa, the extension of the synovial membrane above the knee joint, suprapatellar bursa. Attaches anteriorly to the sides of the patella, as you can see here, and forms the patellar retinacula from the sides of the patella to the tibial condyles. These are the patellar retinacula. Don't confuse this with this structure, which is the patellar ligament or the patellar tendon, the extension of the quadriceps tendon. Okay, the capsule fuses medially with deep part of the medial ligament. We will discuss the medial ligament later, and it attaches the menisci peripheries to the tibial condyles by means of a coronary ligament extension from the capsule. Coronary ligament that attaches, connects the menisci to the condyles of the tibia. So this is the capsule. Don't forget that it's deficient superolaterally for the bursa. The synovial membrane is the most extensive and complex in the body. It forms the suprapatellar bursa. This is the suprapatellar bursa, kept in place by the articularis genu muscle. And the synovial membrane lines the vastus medialis and lateralis, more extensive under the vastus medialis. And this in knee effusion, for example, due to inflammation or trauma, you will notice that the fluid accumulates in the synovial cavity more under the vastus medialis than it is under the vastus lateralis muscle, because the synovial membrane is more extensive under the vastus medialis. And the synovial membrane separated from the patellar ligament by the infrapatellar pad of fat. You see this pad of fat separated by infrapatellar pad of fat, and it forms posteriorly, posterior direction to an area between the condyles, the infrapatellar fold, synovial fold that has two alar folds at the base. Infrapatellar synovial fold, the one you see here. Okay, so this is about the synovial membrane. Of course, it communicates with bursa, communicating with the knee joint. The synovial membrane do not cover the menisci, because the menisci are the articular surfaces. Of course, the synovial membrane in any joint does not cover the articular surfaces, the menisci in this case. Ligaments of the knee. We have the ligamentum patellae. We studied the quadriceps tendon before. The ligamentum patellae is a tough ligament to the tibial tuberosity, from patella to the tibial tuberosity, separated from the synovial membrane by the deep infrapatellar bursa. Deep infrapatellar bursa, which is this area, deep infrapatellar bursa. The oblique popliteal ligament, this is the tendon of semimembranosus muscle. It has an extension, many extensions to the surroundings. One of them is the oblique ligament, as you can see here. It enforces the posterior aspect of the capsule of the knee joint, and the oblique ligament is perforated by the middle genicular artery and nerve. Middle genicular, sometimes called medial genicular artery and nerve. Pay attention here, it's only medial, it's not upper lateral medial or lower lateral, upper medial genicular or lower medial genicular. It's only medial, or middle branch of the genicular arteries of the popliteal artery. Another ligament is the arcuate popliteal ligament, from the head of fibula to the two condyles of tibia, as you can see here. It guards the entrance of the popliteus tendon muscle, popliteus tendon or popliteus muscle, to the medial aspect of the lateral or fibular collateral ligament, to gain its attachment to the lateral epicondyle or the lateral condyle of the femur, the tendon of popliteus. Don't forget that. Guarded by the arcuate ligament, the one you see here. Also, we have the tibial collateral ligament. See the tibial, it's ribbon-like band, 10 centimeters long, descends slightly anterior from the epicondyle of the femur to the upper medial surface of tibia. By crossing that way, it covers the tendon of semimembranosus muscle and the inferior medial genicular artery and nerve. Has a superficial and deep parts. The deep part attaches to the meniscus, medial meniscus. So if something happens to the medial ligament, usually it tears the medial meniscus with it, because it's attached to the medial meniscus. On the contrary, the lateral ligament is not attached to the lateral meniscus. It's crossed by the SGS tendon, the sartorius gracilis semitendinosus aponeurosus, and with a bursa in between. The fibular collateral ligament, on the other hand, from the lateral epicondyle of the femur to the styloid process of the fibula, it's cord-like. It's not a band, it's not ribbon-like, it's cord-like, it's tough, and inferior lateral genicular artery and nerve and tendon of popliteus are deep to it. We saw the tendon of popliteus entering the knee joint, and it's not attached to the lateral meniscus. So injuries of the fibular collateral ligament does not involve the meniscus as well. On the contrary, the medial side has this, it takes, when injured, it injures the medial meniscus as well. The injury is more complex on the medial side. The cruciate ligaments, we have anterior and posterior cruciate ligaments. They are named after their attachments to the tibia. The anterior cruciate ligament from the anterior part of tibia, tibial condyles, intercondylar eminence or area, to the medial surface of the lateral condyle of the femur. The posterior cruciate ligament from it's tougher than the anterior, stronger than the anterior, and comes from the posterior area, the posterior margin of the intercondylar area, to the lateral surface of the medial condyle of femur. As you can see here, it can be visualized from the anterior aspect, so if you have a specimen in the exam, don't get confused with their attachments. Count the attachment to the tibia, not to the femur, because they are named after the attachments to the tibia. The posterior cruciate ligament also covered anterior and laterally by the synovial membrane, and posteriorly it's not covered by the synovial membrane. Okay, so the synovial membrane takes a curve around it, covers its lateral surface and anterior surface, and then the lateral surface again of the cruciate ligaments. Okay. Transverse genual ligament or transverse ligament of the knee. This ligament, it attaches the tip of the anterior cornea of the medial meniscus with the convexity of the lateral meniscus, as you can see here. This is the transverse ligament. The meniscofemoral ligaments, two cord-like ligaments that surround the posterior cruciate ligament from the anterior aspect and the posterior aspect. It's called the meniscofemoral ligaments, and they are attached with the attachment of the posterior cruciate ligament. Coronary ligament extension from the capsule is on the edges that connects the menisci to the tibial condyles on the edges. It's more lax on the lateral side because the lateral meniscus is slightly more mobile than the medial meniscus because of the action of locking and unlocking of the knee. So it's more lax on the lateral. The lateral coronary ligament is more lax than the medial coronary ligament. And now we're done with the ligaments. Now the menisci, they are pieces of fibrocartilage, semilunar in shapes, as you can see here. The cut section is triangular. It's thicker on the outside than the inside. The inside is thin to make a rather concave surface to increase the depth of the articulation of the knee joint. This thin surface is avascular. Only the outer margin of the cartilage is vascular. The rest is avascular, so it takes its nutrition from the synovial fluid directly, and that's why if tears involve the inner sides of the menisci, it takes longer time to heal because it's avascular area. Okay, I also want to withdraw your attention to a question in this area about the how the structures attached or arranged in the intercondylar area. The first structure is the anterior cornea of the medial meniscus, then the anterior cruciate ligament, then the anterior cornea of the lateral meniscus. So remember, two corneas with the anterior cruciate ligament between them. Then the posterior cornea of the lateral cruciate lateral meniscus, then the posterior cornea of the medial meniscus, then the last structure is the posterior cruciate ligament. So it's ligament, meniscus, meniscus, okay, then meniscus, ligament, meniscus. This is the arrangement of structures attached in the intercondylar area, and I was asked about this before, how they are arranged. The most posterior is the posterior cruciate ligament, and the most anterior is the anterior cornea of the medial meniscus with the transverse ligament of the knee, of course. Okay. The bursa around the knee, anterior bursae like the suprapatellar bursa. This is the extension of the synovial membrane upwards, the suprapatellar bursa. There is the prepatellar bursa between the patella and the skin. There is the superficial infrapatellar bursa below under the skin, and the deep infrapatellar bursa deep to the patellar ligament. This one, the deep infrapatellar bursa. Okay. Also around the knee, the lateral and medial bursae between almost every muscle, every tendon that passes the knee and or attached around the knee and the knee itself, and some of them may communicate with the synovial cavity, and the most common to communicate with the synovial cavity is the popliteus bursa, the gastrocnemius bursa, and the semimembranosus bursa. Relations of the knee. Anterior, we have the patellar retinacula, the ligamentum patellae, the pad of fat and patella. Posteromedially, we have the semitendinosus, semimembranosus, the SGS aponeurosis, and the medial ligament. Posterolaterally, we have the common peroneal nerve along the tendon of the biceps and the lateral ligament of the knee, and the tendon of popliteus. Okay. Posteriorly, we have remember the skin with branches of posterior femoral cutaneous nerve, then the structures inside the popliteal fossa, the tibial nerve being most superficial and crosses the vessels from lateral to medial. Then comes the popliteal vein in the middle. Then the deepest or the most anterior structure is the popliteal artery and its branches, the genicular branches. Okay, so these are the relations of the knee. So don't get surprised. Yes, there are relations of the knee. The blood supply of the knee comes from the anastomosis around the knee joint. The major supply, of course, from the geniculars of the popliteal, the upper and lower lateral and upper and lower medial and the middle genicular or the medial genicular. Also the descending branch from the femoral descending genicular artery. Descending branch of the lateral circumflex femoral artery shares in the anastomosis. The circumflex fibular artery shares in the anastomosis. Anterior and posterior tibial recurrent arteries also shares in the anastomosis. So it's an extensive anastomosis. For any part to be occluded, it's compensated from all the surroundings. This happens because, for example, when we sit with the knee flexed, when we sit on our knees, of course some of the vessels will be occluded, but the blood supply will be continuous through the other components of the anastomosis around the knee joint. Okay, nerve supply of the knee joint, like Hilton's law, for any muscle that acts on a joint, its nerve supplies the joint. So expect supply from the femoral, tibial, common peroneal, and obturator nerves. Also in locking and unlocking of the knee, when we extend the knee, the femur rotates medially on the tibia, so that the ligament will be at maximum tension. That's why you'll find the fibular collateral ligament directed downwards and backwards, and the medial collateral ligament directed downwards and forwards. They will be taught in this movement when the femur rotates medially on the tibia. And now at this position, you must unlock the knee before you flex the knee. by lateral rotation of the femur on the tibia. This is done by the popliteus muscle. So this is the action of the popliteus muscle, that it lateral rotates the femur on the tibia in unlocking of the knee before flexing the knee. Another thing I want to draw your attention to is effusion. If there is a knee effusion, this will push the patella up. It will float on the effusion. So there will be a distance between the patella and the femur that you can't tap. It's called patellar tapping. Patellar tapping is a sign of knee effusion. Also, inflammation of the bursa we discussed, especially the anterior bursa. The prepatellar bursa is called the housekeeper's bursitis. Semimembranosus bursitis, on the other hand, one of the ways of diagnosis is flexion and extension of the knee. It's a fluctuating swelling at the back in the popliteal fossa, and tense in extension. It's pushed backwards, and soft or disappears in flexion, sinks inside the popliteal fossa. This is the diagnosis, one of the diagnosis methods for the semimembranosus bursitis in the semimembranosus bursa at the knee. Okay, this concludes our talk about the knee. Thank you. I hope you got the maximum benefit from this lecture, and thank you very much for watching.